So, thank you, Marcus. Dankeschön, sehr gut. A great lead-in for this second part regarding diagnosis and treatment profile of RAI and managing radioiodine refractory disease. I couldn't agree with you more with your statements regarding tailoring treatment, personalized medicine, and really coordinating the care for each individual patient. I remind you again, that is not my objective to tell you what to drink or what to do. My goal is to, in the first presentation, go through the limitations, and in the second presentation, to present some of the same concepts that Marcus presented regarding managing potentially radioiodine refractory patients until we obtain more information. The objectives describe the next steps for revision of the classifications of radioiodine refractory disease, list potential approaches, and a lot of caveats to help manage and minimize excluding a patient who might benefit from I-131, rather than automatically assuming that there would be no benefit. Discuss future areas of research, which Marcus also alluded to. So for the next step, one of the things that's already been established is a multi-specialty international team to look at the classifications of radioiodine refractory with extensive discussions of the literature. The present plan is to use the Delphi approach, which very briefly, for those who aren't familiar with it, and I was not that familiar with it myself, is a method to bring experts together and to allow multiple iterations of opinions and then distribution of data, and then reforming all of that and reconsidering it all anonymously so that there's no individual bias. Well, there's individual bias, but they're allowed to express their individual biases and then work out what is a consensus. The interesting thing about a consensus, if you look up the definition in Webster's dictionary, there's no consensus on what a consensus is, which is very interesting. Now, the team includes representatives from ATA, EANM, ETA, SNMI, and actually this initiative was sparked through the efforts of the 2019 Martinique meeting. And we have a representative from SNMI India, ICA. We've asked multiple other societies of which we're waiting a response. And then we've also invited additional individuals with special interest in therapies such as a radiation therapist, etc. Now, in the interim, in place of implementing cookbook definitions, what I'm recommending is exactly what Mark said, and that's practicing medicine and tailoring it, as he used the word tailoring care to the individual patient, or personalized medicine again. Now, I really like the concept that Marcus proposed, which is likelihood. And in the, I think I can say this, in the draft for the SNMI 2000, I guess it will be 22 guidelines, this table will probably be included in that publication. And I think in thinking about the likelihood of radioiodine refractory disease, it's really good to look at it in terms of a likelihood. So if one's doing a negative or doing diagnostic scan and it's negative, what's the likelihood that they're radioiodine refractory? It's low, but maybe in some situations, depending upon patient desires, which I'll talk about more in a minute, or comorbidities, maybe all one will use as a criteria is a diagnostic radioiodine scan, but really still understanding the limitations. And then at the other end of the spectrum is very high is progression over a short period of time after the administration of a maximum safe dose of I-131 with proper patient preparation. So I think where we'll move in the international committee using the Delphi approach is that we'll probably develop a more extensive likelihood ratio like this slide with more complete information and suggestions, but not absolute definitions. So again, practicing medicine. I'm going back the wrong way. So number one, and Marcus had this in his slides, is first of all, if you run into a patient that you're considering as radioiodine refractory, there's absolutely nothing wrong in referring the patient. As I travel, now don't travel, but as I traveled in the past, frequently I had sensed that a facility would not consider referring the patient because that was seen as a negative, that was seen to reflect negatively on their facility, that they should do it all. No facility does everything. Some facilities are experts in particular areas, and there's nothing wrong with referring a patient. Now, well, where do I refer? On the Society of Nuclear Medicine website, there is a page open to everyone, whether a member or not, regarding a previous survey that we've nationally performed for the Society of Nuclear Medicine regarding sites that perform dosimetry, sites that perform simplified dosimetry. The contact persons are there, they're listed by state, and one can see if there is a facility nearby or not too far away that the patient may be willing to go to, and you can refer the patient to that facility. Now, number two, do not consider, these are the caveats, a patient with differentiated thyroid cancer to be radioiodine refractory just because that diagnostic scan is negative. We've hit that several times. However, do not consider that a patient is radioiodine responsive just because the diagnostic scan or the post-therapy scan is positive. It may have avidity, but it may not have enough avidity to deliver a significant rad dose, like the conversation that Marcus had regarding Dr. Hanscheid, which is an excellent paper. Remember, not all scans are created equal. One, in trying to assess, when one is an endocrinologist trying to assess the quality of the scans from the facility that they're referring to, I recommend they go to the Thyroid 2019 article that I listed earlier. And again, if you need that, request the slides, it's listed and you can pull that. And the way to assess it is by looking at several of the techniques that improve the yield of information from the scan. Sometimes you can ask the nuke med physician, well, did you do a spot image of that area? And very politely request, and you might learn whether you're getting good images or not. Number five, assess the quality of the diagnostic post-I-131 scan image, same item. Measure spot urines. This is for both diagnostic and post-therapy. Was the TSH elevated? Time of diagnostic imaging after administration of radioiodine, appropriate technique, SPECT CT, not just whole body, but SPECT CT. Marcus showed some really great slides of really prominent star artifacts, and then the SPECT CT greatly differentiated whether that was thyroid tissue or lymph nodes. I went, this was several years ago, I went to a national meeting on thyroid, and every slide that was shown was a whole body image. And many of them had a star artifact on it. As Marcus pointed out, just because it has a star artifact, don't necessarily conclude that that represents normal residual tissue and a lot of tissue left behind. Duration of image acquisition is important. Time of imaging, 48 hours versus 72 hours for I-131. And then perform post-I-131 scans at an appropriate time interval, as I already discussed. A predetermined cumulative prescribed activity of I-131, as I already mentioned, should not be a sacrosanct definition of radioiodine. The patient's response to the I-131 therapy is the very best classification, but one still has to consider multiple additional factors. Do not use the criteria of just progression. Assess the character. What was the metric used to decide that the patient had a response or not a response, and the duration of that? And also how much, as I already pointed out, I-131 was administered. Now, a warning about this next slide. This is never accepted in the course on slidology. It's too busy. But I included it because when the slides go out, you'll see an example of looking at a patient who's had progressive metastatic disease, and then a thought process, an example of using I-131, what was their response, how does that fit in, and the key factors are the amount of administered activity of I-131 that was administered, and the duration of stable disease or remission. Doesn't have to be complete remission. It could be just changing from progressive disease to stable disease. Number 11, what are the criteria for a response from the prior I-131 therapy that warrants consideration of another one? Examples, as I mentioned, the metric, very important. What's the structural response? RECIST criteria is the most used criteria, but I would also emphasize, and again, this presentation is to provoke, RECIST is a very important criteria. Now, one of the reasons that it was developed is you have to have a specific criteria in order to do your prospective studies, whether with a radioisotope or TKIs or whatever one is treating with. Now, one doesn't necessarily have to use RECIST criteria for your patient. For example, if a patient is progressing, let's say by RECIST criteria, and now you stabilize the patient, that may not necessarily be considered a response. It may be, depending upon how that criteria is used, as a failure. However, for me, if I have someone who has pulmonary lesions that are getting bigger, and I have, say, a TG, and it's a doubling time of less than 1 year per my Ouchie's data, that patients with doubling time of less than 1 year have a worse prognosis than those patients who are doubling time is longer than 3 years. And I now treat with I-131, and the progressive disease of the lesions on CT or chest X-ray stabilize, and the TG doubling time dramatically slows. Let's say it went from 1 year to 3 years. They're still progressing a little, but there's been a significant change that doesn't meet RECIST criteria. I still consider that a potential therapy, a response, and not a failure. So modified RECIST criteria. What thyroglobulin response? What's the duration of response? Now, a frequent question that I get is, well, what do you consider a reasonable duration? Well, it's a spectrum. It's not an absolute threshold. Certainly, if they respond for 3 months, 4 months, 5 months, that's probably, and certainly in my opinion, I would consider that not significant enough, as long as the administrative activity was enough. If it was 100 millicuries, I would say, well, it's not a good response, but was that because there was an inadequate administration given? But if it's over a year, like the case I presented earlier that went 14 months, progressing and then treated and then stabilized for 14 months, I would consider that a response. And I would consider another I-131 therapy. Now, where's the cutoff? Is it 12 months? Is it 9 months? It's a spectrum. It's tailoring to the patient. I think, as a general rule, semi-arbitrarily, if it's 12 months, then one should consider another I-131 therapy. Other factors come in, which would include side effects that I'll mention in a minute, and the patient's perspective. If it's less than 6 months, I would consider that not a success. 6 to 12 months, that's more debatable. Patient's criteria of acceptable response becomes very important. Additional factors that need to be considered: how much activity, as I already mentioned, prior to the therapy has been given, frequency and severity of side effects prior to the I-131 therapies, or if I phrase that a little bit better, prior to the actual I-131 therapies that were administered. Is the patient a minimalist or a maximalist? This is a very nice concept that came from Koopman and Hartspan in a book called Your Medical Management. And I highly recommend this book to all of you as a patient, not just a physician. It really took a simple concept and explained it very nicely, that we as patients ourselves may in some situations want to be a minimalist. Some patients don't want to take the vaccine. Some say, I'm going to absolutely take the vaccine, and they're a maximalist. Same for surgery. I want to be followed. I'll be a minimalist. Or, no, I want everything that you can do done. One of my favorite patients, both as a patient and a person, was a 30-year Marine colonel, and you could almost guess he was a maximalist. He wanted to take the hill. He wanted everything. Give me the maximum safe amount I can give, and he went for everything. That may not be true for Mrs. Jones, who's 80 years old, and she says, no, I'm doing fine. Let's just follow. So it's very important to know other factors such as the patient, a minimalist and a maximalist, and you really need to look at yourself. Are you a minimalist or a maximalist? Now, in the past, I was frequently known as Dr. Dosimetry because I was a big advocate of dosimetry. Dr. Leeper in 1980 from Memorial with Benoit and Leeper actually helped me get started. And I was very grateful to Dr. Leeper. And in the beginning, I was a big advocate for dosimetry. As one ages, one gets a little more reasonable and smarter. And what I decided to do was to present the options. And then I try not to give an answer regarding whether I would suggest a higher activity based on dosimetry or an empiric activity, and I would allow the family to go home and think about it and come back. My favorite little story is they used to say, well, if it was your wife, what would you do? Now they say, if it was your granddaughter, what would you do? But anyhow, it's really important, in my opinion, to educate the patient, try to be unbiased, and not give them the flavor that you're a maximalist or a minimalist, and then let them weigh that and come back. Almost always when they come back, they will have made the decision for themselves or for their daughter. Consider, again, referring the patient, but in this case, refer the patient for clinical trials using trametinib or dapirfenib. Now, Dr. Luster presented the nice images from Alan Ho's article in the New England Journal of Medicine from Memorial Sloan Kettering, showing how he had an I-124 PET scan and was treated with 4 to 6 weeks of selumetinib with marked resensitization, as one uses the phrase, or redifferentiation. And here's the things to come based upon Alan's work, and there was actually earlier work with rosiglitazone, but here's the things to come. Graber, who is at MD Anderson in Houston, and he published this article, and this is just one of his 13 patients that he published on. And this is already here. This was not part, as I understand, of a research study. Now, the patients were considered radioiodine refractory. They started on dapirfenib and trametinib, and that was part of the research study. However, at 4 to 6 weeks, and we may be able to image earlier per Nagaraja from Germany, we may be able to image even earlier after trametinib and dapirfenib. These are the images. This is pre-trametinib. This is pre-trametinib, and this is post-trametinib. He went on and treat 8 patients. One of them didn't even have a response, but out of the 7 that had a response or a redifferentiation and were retreated, most of these had a very good response. So this is already here. If the patient, let's say, is BRAF positive, they're going on trametinib or dapirfenib, then consider doing a radioiodine scan at 4 to 6 weeks or possibly earlier as we learn more. This completely changes the paradigm of classifications of radioiodine refractory disease. And to address Dr. Gulick is in regard to molecular imaging, this could be very important in helping identify which patients have a reasonable likelihood of being redifferentiated. Another factor that's coming with this is not just redifferentiation, but taking I-131 uptake that is already identified in images that we already know they're radioiodine avid, but giving them trametinib or dapirfenib and increasing the relative uptake compared when they're not on those drugs, because now we will deliver more rads per millicurie administered. And the key is rads delivered. That's what we're after. Consider a blind I-131 therapy. Now, blind means that the diagnostic scan was negative. And as I've already pointed out in all those, I think it's 12 articles earlier, when blind therapies were administered, there were many patients that would be positive on the post-therapy scan. So blindly given I-131 therapy with an empiric or a dosimetrically-guided prescribed activity, and you'll identify whether the patient does have I-131 on the post-therapy scan. Now, that doesn't change what you've done because you've already done it, but it may help determine if there is a response, whether you might consider another blind I-131 therapy later. Now, the pushback that I received from some of our endocrinologists, not all of them, and we have a thyroid cancer conference every week with typically 25 attendees, mostly endocrinologists, was you're giving a blind I-131 therapy and you may get no benefit from that. Yes, that's correct. And I may get some side effects from that. So how can we manage that? And one of my research fellows started to consider, why not do a 30 millicuries probe scan? So we're going to give a higher administered activity in order to improve our ability to see whether there is functioning tissue. And we've, I think, done about 10 patients in this situation, which is not part of a study. It's a clinical decision to manage the patient. And if the 30 millicurie scan is positive, then we immediately administer the remainder of the dosimetrically determined dose. If the 30 millicurie scan is negative, then we give no further activity. Now, the negatives of this and the reasonable criticism is, well, you may stun the patient with 30 millicuries. You may, but we give the therapy, the remainder of the therapy dose, if we're giving it, within 18 to 24 hours after that 30 millicurie scan is done. I mean, we do the scan 18 to 24 hours after the 30 millicuries is administered. And if it's positive, we give that afternoon the remainder of the dose. If Ross McDougall is correct, and he's now retired, but if he was correct, there's very little stunning, if any, within the first 18 to 24 hours. If you wait for 72 hours, you start to have a therapeutic effect and thus stunning. So in regard to the issue of stunning, we believe, but I can't prove, that if we give it fast enough right after that 18 to 24 hour scan, we're not getting any stunning. And I'll show you a scan that at least anecdotally confirms that. Now, the other problem with this is, could the patient have uptake on a 7-day scan and not on an 18 to 24 hour scan? And yes, we've had one patient that did light up, and so maybe we missed an opportunity. However, the rationale or the empiric thought, no data on this, is that it was unlikely we could have gotten a therapeutic amount of rads delivered to the metastatic disease. So consider a 30 millicurie probe scan, image 18 to 24 hours later, be immediately prepared to give any balance of the I-131 that afternoon, and always do a post-therapy scan at 3 to 7 days. Now, here's a 30 millicurie probe scan. Now, in this patient, the diagnostic scan is shown on the left. This is by Wu Di, who published in the World Journal of Nuclear Medicine. And here's the 30 millicurie scan. Clearly, there's a focal area in the left humerus. This was already known. There was a lytic lesion there. It was not biopsied, but the patient went on to get the remainder of the dose. Now, so this at least helped us better screen out those that are not going to get a response and those that have a chance, but it doesn't mean they're going to get a response, but have a chance to have a response before they go to a TKI. Now, here's the 7-day scan performed in that same patient, and clearly there's not just the left humerus, there's additional mets here. In fact, I think here you could argue there's 3 mets that are seen. Now, with this activity, there's a higher likelihood that they might get a therapeutic response. Again, I can't prove it, and I don't have the data to indicate that, 80%, 20% of these patients responded. But these are patients who are end stage. They have metastatic disease, they've progressed, they're about to go on a TKI. This offers them at least the chance of having a therapeutic response. And if they get 12 months out of this, that's 12 more months of benefit, and then they can go on their TKI or take another therapy. So in conclusion, the various authors who developed and upgraded the classifications, I highly recognize their pioneering time and effort. The classifications of radioiodine refractory are not sacrosanct. You've got to know the limitations, and one should know the many options available to manage these patients. Again, I'm not trying to tell you what to drink or what to do other than to tailor your patient management, personalized medicine, practice medicine. I hope you remember this slide. We may think we're doing a really great job. This guy sort of clapped himself when he was done, and he cleaned the wrong car. Now, this may be the new snowstorm coming to Germany for Marcus in the next week. As I age, I like this saying, join those who seek to know the truth, not those who think they know the truth. And how are we for time? I have 2 minutes left. Cesar?
Go ahead, please.
I'm going to tell a little joke.
Of course.
I always like to leave on a happy note, and obviously I'm starting to age, and so I start to accumulate senior jokes. So here's this couple. Man and wife have been married, and he's 101, and she's 99. They've been married 80 years. 80 years, they're having a glass of wine. And she says, I couldn't have done it without you. And he says, is that you talking or the wine talking? And she says, it's me talking to the wine. So I hope people are laughing out there. This is the team that made it all possible for me. They were fantastic. And this is my research team. We obviously have a good time, and happy spring to all. And I hope it comes to Germany shortly. Thank you.